All right, it is 12:15. I see some people are still joining, but we'll go ahead and get started. There'll be some time for questions after, and I'll stay a little bit extra because this is an important topic and one that is an important message to get out there. I think there's like a longer session that we give of this called the Spark event. So that's something that we give once to twice a year to providers, and then once a year to caregivers and the community. So we gave one on May 7th of these sort of 3-hour Spark events, which is basically a more comprehensive version of this 20-minute talk. And the one in October would be our next one. So Lewy body disease, so that's got a lot of different names. Dementia with Lewy bodies. Lewy body disease just really encompasses the whole disease process, not just dementia. And it's really the second most common, but it's the most commonly missed, and that's why it's an important topic. So I think there's a lot of misunderstanding around it, so hopefully we can clarify any questions you guys have about it here today. So the code will be listed down in the bottom there for your CE. And I did add this on. So I'm actually the principal investigator of our newest study that we've got going on. It's going to be, I'll have a slide on it at the end for Lewy body disease. Objectives here. So I want to just give you guys an update sort of on the core clinical criteria. How can you help recognize this in a clinic? And then really starting to recognize the prodromal and supportive features of Lewy body disease and DLB. That's actually extremely important on being able to raise your radar for it. There's a Lewy body composite risk score calculator that we have that I'll include on there. And then, you know, we call it dementia with Lewy bodies. There's things that happen before dementia. We know there's mild cognitive impairment stages of this. And so we really need to be able to start recognizing this sooner rather than at a later time point in the disease process. One reason is because treatment options can really help patients, right? And the sooner you start those, the better outcomes are. So we're going to discuss what some of those treatment options are. So I always like to have a case in here just to help solidify things. So this is a 72-year-old Vietnam War veteran who has 3 years of worsening memory issues. Symptoms really were most noticeable after a low back surgery. Just didn't quite wake up the same as he went in. Wife describes these kind of fluctuations, maybe even periods of staring off. He seems absent-minded at times, but then seems normal at other times. It's hard to predict how he's going to be doing, even hour to hour. He's more apathetic, decreased hobbies, does have a history of sleep apnea, but not using CPAP. And, you know, just other discussions on like motor, there is some slowing of his walking speed. There's been 2 unexplained falls that are sort of a red flag. On review of systems, he's got constipation. He describes dizziness, which when you elicit more history, it's more of lightheadedness when standing. He's got insomnia, nightmares, a lot of sleep-related problems. His wife describes him occasionally yelling out in dreams and accidentally struck his wife once. Actually, they're actually sleeping in separate beds now because of some of these nighttime behaviors. And he has excessive daytime sleepiness. On as far as med list, so he's had a long history of migraines that have been difficult to treat. He's actually on valproic acid that's been helping his migraines. He's on oxybutynin for urinary urgency and metoprolol for hypertension. We see this used oftenly. It's not a great antihypertensive, but it could also be contributing to that lightheadedness with standing as well. On his neuroexam, so, you know, when I do my little brief cognitive test, he scores 28 out of 38. That's in a mild dementia range. Missing points on cube and clock, so visual spatial construction, missing points on attention and encoding. And then there's a little bit of issues with memory as well. You also notice that, so he's got decreased facial expression. We call that masked faces, and decreased voice projection. The voice is just quite a bit softer than it was in the past when you ask his wife. And then decreased arm swing when he's walking. If you kind of pull on his shoulders, he stumbles back into you. He's got a positive pull test, and likely why he's been having some falls. You get an MRI scan, and there's nothing like that jumps out at you from a vascular disease standpoint. This is a coronal image where this is the top of his head. I'll tell you there's some central atrophy here in the middle, but the hippocampus structures, which we think of important for short-term memory and often what we think of in affected in Alzheimer's disease, these are within normal limits for his age, so this isn't the problem. At this point, right, you kind of, if you think about some of these criteria, it may not be immediately clear to you, but if we want to diagnose someone with probable dementia with Lewy bodies, one, it has to be enough to start to interfere with their daily activities. And so that's where that dementia component comes from. And then we sort of look at our core criteria, which is it's four criteria is what we have. And this has been reestablished in 2017 with some small updates. So the 2017 core criteria lists these out as REM sleep behavior disorder, which is acting out dreams at nighttime. This one is often, so I listed these in kind of the order we often see them present. So this can really even occur years to decades before symptoms in some individuals. For others, it's much closer to when they present. But he's got this going on. He struck his wife, he's yelling out of dreams. Cognitive fluctuations are what those descriptions were, these kind of absent-mindedness, really doing well sometimes, but very confused other times. So you'll often hear staring off or spacing out, zoning out. Those are important to ask about. He's not having visual hallucinations. The core criteria recommends these need to be well-formed, complex visions. These are often of people or animals. But I will tell you, there's a spectrum of this. And, you know, patients will often first have paranoid delusions. They'll often have feelings of presence, like someone's in the room with them, well before they have visual hallucinations. But he doesn't meet this, at least, core criteria. He was having some paranoid delusions, though. For Parkinsonism, we're looking for postural instability, you know, usually a history of falls or near falls. Slowness with movement is bradykinesia, rigidity, stiffness, that's the decreased arm swing. And then he doesn't have a tremor. Oftentimes patients don't have a tremor. That's often something that comes much later. And sometimes their tremor isn't a classic rest tremor that we think about with Parkinson's. It's sometimes more bilateral, sometimes it's postural and action related. So I very often hear, well, they don't have visual hallucinations or they don't have Parkinson, like they don't have a tremor. This can't be Lewy body disease. That's absolutely incorrect. And so, you know, you can have these 2 out of 4 criteria and meet that definition. For him, for this specific individual, and things that you want to think about is removing things that could be worsening things, right? So oxybutynin crosses the blood-brain barrier, and it's anticholinergic, and it has been shown in study after study to impair cognition. So really important to switch this over to something that does not do that. There are non-anticholinergic versions. So Myrbetriq is the one that has been around a little bit longer. There's actually even newer ones out than that. Obviously, the main concern here is cost with these, but it kind of depends on what the symptoms are and how severe they are, and then whether you can get cost coverage. Trospium or darphinocin or colteridine are other anticholinergics, but because of their structure, they don't cross into the blood-brain barrier quite as easily. So they're better options than oxybutynin, at least. But you know, we also think about, as somebody has a neurodegenerative disease, their blood-brain barrier is actually a little bit weaker. So still, these aren't ideal options, but they're better than oxybutynin. For him, so titrating off the valproic acid, that's a central nervous system depressant. It's contributing to some of his cognitive slowing. We were actually able to get him in with a migraine specialist, and he gets his Botox injections now for this, and that's been working very well. It takes a little while for those to take full effect, but then they were able to wean him off of his valproic acid over time. So for managing the cognitive symptoms, it's starting an acetylcholinesterase inhibitor, right? And so the most common one we use is Aricept, or donepezil is the generic of that, right? Most of my patients, especially with Lewy body disease, tolerate this just fine. He did not, so he had significant nausea with it. We even tried splitting the doses of kind of, you know, with breakfast and dinner time, and he was still having issues. So switched over to a rivastigmine patch and slowly increased this each month to our max dose is 13.3, and then saw him back just to see how he was doing with some of these changes. And his cognitive testing improved from 28 to 35, right? So that's a pretty dramatic improvement. He was still having issues with visual spatial. We don't expect that to get too much better, but it was really helping his attention and memory side of things, which is what we see often happen with this specific drug treatment. For sleep symptoms, started melatonin. That in about half of my patients, melatonin alone can be enough to help with REM sleep behavior disorder. 3 milligrams might not be enough. I don't recommend starting it at 10. That can be way too much for some people. But basically, you want to start low and go slow. So about every week, you can increase up by about 3 milligrams. I've got some people actually on 20 milligrams, but that's not the norm. This helped with the insomnia, but he was still having a lot of PTSD and paranoia events at nighttime that were waking him up. We don't know as much about his REM sleep issues since they're sleeping in separate rooms, but we went ahead and started a very low dose of clonazepam. That's really second line after melatonin in this, and that works very well. He needed just a dose of 0.5 at nighttime, and those events have essentially resolved, and they've continued to resolve. It's also very important to be treating sleep apnea, right? I can't help your daytime sleepiness much, or it's actually thought to be one of these potential disease accelerating risk factors, right? If you're not treating your sleep apnea, then that might make things worse over time. So I have a very low threshold to check a sleep study, especially if they're having excessive daytime sleepiness. So that's just another important point. For managing Parkinson's symptoms, so this is really kind of later down the line, right? We only want to start one thing at a time. But in about 2 months, we were able to get him started on carbidopa levodopa. I start this at a very low dose of a half tablet each week, and then increase each week to a max of 3 tablets 3 times a day. Some patients notice, hey, there's no difference between 2 tablets 3 times a day and 3 tablets. So then we just go back to the dose, with the least amount of medication that's helping them. This individual did get benefit with 3 tablets over 2, so we stayed with that. It's important to take this medication away from meals because it disrupts absorption into the brain. So you're just getting less bang for your buck if you're taking it with meals. His movements did improve with this, but it wasn't just the medication. It was a combination of getting him moving better, but also with physical therapy, right? So he did a Big and Loud program, which is a Parkinson's specific physical and speech therapy program. And then also got involved. They've got this really unique, I think it's called Move On or something like that, Life. And they have these Parkinson's boxing classes. I've got a number of patients that have been getting involved with these, and it can really help from a cardio workout and a balance perspective. He was doing quite well, but during some of his jump rope routines, he actually tore his meniscus, right? And then, so it was sort of like, well, I want you to exercise. You can't exercise because of this injury. So he actually needed a surgery. And we were able to work with local surgeons to avoid general anesthesia. That's another important tip here. So especially for elective lower extremity surgeries, really try to have your patients go through maybe a local anesthetic. Spinal block is the most common way to do this with moderate sedation. So they're kind of like when you get a colonoscopy, right? So moderate sedation, but not the general anesthesia. Really limiting post-operative pain meds is important as well, at least from the opioid category. He actually did quite well even without any opioid medications. And he had no delirium post-operatively, right? So that's really key. Those are those pitfalls that we want to avoid in managing Lewy body patients. Starting an SSRI was necessary at this point too. He was having a lot of irritability symptoms, really kind of lashing out at his family members, and there was some suspicion of depression as well, but anxiety primarily. And so started a low dose of an SSRI and titrated that up. So usually what I'll use is Lexapro or escitalopram, and then sertraline or Zoloft. So he's been doing pretty well. He's kind of limiting some of his jumping routines, but actually, interestingly enough, saw this patient just this week. So now I should probably change this to 4 years later. His most recent testing is 32 out of 38, but this has been 4 years now of very mild changes over time. And you know, there's just a lot of things that go into this, but we can really impact this sort of disease trajectory. He was in a dementia range when we first saw him, right? And so it raises a question, right? What is the trajectory of Lewy body disease? We know this is a neurodegenerative disease. We know this is something that's going to get worse with time. You know, if you look up the literature, it says actually at a point after diagnosis, it's somewhere between 3 and 5 years to death. I would argue that a lot of that is because we're diagnosing it way too late. So that's one of the issues. And we're also not avoiding some of those pitfalls. So early recognition is key and early intervention is key. You know, one of the questions is why can some of these patients improve so much with medication? It tends to really help that attention and encoding of information. I'll find when I'm testing somebody, if I ask them to remember 4 words, I have to repeat it 3 times, 4 times even to get those 4 words to stick. Once they stick, their memory is actually fairly good, but it shows up as a memory complaint by the patient's wife because he doesn't remember anything we talk about. It's not practical to repeat everything 3 to 4 times, right? But this medication can help with that. Usually their hippocampal structures are still intact. Actually, if we see shrinkage of those structures, even though we're diagnosing somebody with Lewy body disease, then that really suggests AD co-pathology. So Alzheimer's co-pathology is actually very common in about 30 to 40% of individuals, but that's partly why we get the MRI to look for that. And so these individuals are on thin ice, right? They have very limited cognitive reserve. I actually see just simple things as much as a urinary tract infection can send somebody into delirium. Anesthesia can do it. A post-op or an ICU stay can do it. Anticholinergics, antidopaminergics. These patients should never get Haldol. They should not be getting dopamine blocking agents, even if they're having delirium in the hospital. For some tips on cholinergic medications, so I always start with donepezil. That's the cheapest. It's the easiest to take. It's usually once a day. I do try to divide it to twice daily if they're struggling to get that full dose in. We've got a number of patients up to 15 to 20 milligrams throughout the day. That's always in split doses. You know, if you do give it at nighttime, that's less bioavailability kind of when it's peaking, right? During the daytime, the drug's peaking at nighttime. It can limit some of the side effects if you give it at nighttime, but then you can also get different side effects. And particularly with Lewy body disease, it can really worsen their nightmares and REM sleep behavior disorder. So I find myself often just moving it to the morning fixes that issue. My next line agent is usually galantamine. I generally try an extended release version of this instead of doing the twice daily, but either one's an option. And then I don't really ever use rivastigmine oral. It basically has twice the side effect rate of donepezil, and it's twice a day. And you usually can't reach doses that are as helpful because of all those side effects. So I do often use a rivastigmine patch, and that's primarily if there's GI side effects with those other 2 oral medications. So this is the standard dose is 9.5, very similar to the 10 milligrams of donepezil, but we do have a 13.3 milligram patch. It's important that for proper skin care, that's probably the most common side effect that patients encounter as far as skin irritation. So good skin care is important. Things that you have to be aware of, right, and counsel patients on. Acetylcholine gets released when you eat food, right? So that's what helps you digest food. You don't want to take this on an empty stomach. You're guaranteed to get GI symptoms if you do that. So taking it with food is important, sometimes even after food. Usually some protein in the food helps too, but these are the symptoms that patients can get even with that. So we try to split doses. We use these different versions, right, to try to combat those. You do have to think about the heart. It's a less common side effect, but if you ever start somebody on this and they just feel really lightheaded, fatigued, they're really worn down, I definitely recommend checking an EKG. And if they've got any heart history, then you should get kind of a baseline EKG before starting this. We want to make sure they're not having bradycardia, secondary heart block. QTC prolongation can be seen in donepezil, but these are things to think about, right, with this medication. Just as an overview real quick, Lewy body disease is a systemic disease. So we get all these autonomic symptoms, right? Commonly orthostatic hypotension, constipation, runny nose after eating. Cognitive impairment is usually multi-domain, but it's not isolated to memory. Usually it's involving attention, executive, visual spatial. The motor symptoms we've discussed already. Sleep disorders. I've never seen a patient with Lewy body disease that doesn't have a sleep disorder, whether it be REM sleep or insomnia or obstructive sleep apnea or restless leg syndrome, right? These are very, very common in Lewy body disease. If you've got anybody with cognitive issues, sleep issues, and especially neuropsychiatric issues, then you got Lewy body disease has to be on your radar. Depression, apathy, anxiety, ranging all the way to visual hallucinations. These are all neuropsychiatric features of the disease, oftentimes paranoia. Misidentification syndromes are very common, so they may mistake their wife for an imposter version, things like that. The timeline of this disease, so we know that there's many years of prodromal symptoms that can occur first, with REM sleep behavior sort of being quite common, decreased sense of smell, autonomic symptoms. These are often 5 to 10 years, but not for everyone. I've had a patient where it was up to 40 years they've had REM sleep behavior disorder. From the mild cognitive impairment stage, it's this non-amnestic presentation primarily. And then the core criteria, right, that we have for dementia with Lewy bodies, this is actually moved to mild cognitive impairment. So these exact same criteria, but with somebody with mild cognitive impairment, we're using that on the research side. I use it in the clinic. So I will diagnose somebody with probable Lewy body disease, even if they don't have dementia, particularly if they're meeting this criteria. We're doing a lot of research in this sort of prodromal stage. So, especially if you've got REM sleep behavior disorder and you're cognitively normal, it's this nice acronym of NAPS, right? But the North American Prodromal Synucleinopathy Study, there's multiple sites around here. They're really looking at trying to figure out which biomarkers might be predictive for conversion, right, to either Parkinson's disease or Lewy body disease. And the goal here would be to enroll patients in preventative trials. Here's the composite risk score where I'm already short on time. I'm going to stay a little bit after for questions if anybody wants to. But motor-wise, there's 4 questions here. We ask about postural stability. We ask about tremor. We ask about slowness with movements and pauses with moving. Those are the motor symptoms. And then the more non-motor symptoms are sleep-related. There's 2 questions. The sort of fluctuating cognition gets captured in these 2 questions. Visual hallucinations. Are you seeing things that might not really be there? Is another way to ask that. And then any autonomic symptoms, including that orthostatic side of things, right? So this has been studied by Dr. James Galvin and many others in the Lewy body groups. Just scoring 3 yeses here already puts your radar up for Lewy body disease. So there's an area under the curve, particularly if you're comparing it to Alzheimer's disease. If you're like kind of between Alzheimer's and Lewy body disease, if they're meeting a lot of these yeses, then you're starting to shift your thought process there, right? So this is it's a very sensitive tool for trying to detect Lewy body disease. For these visits can be long and complicated. I just showed you how it's a systemic disease. When you're doing cognitive testing, there's a lot of slow processing speed that can slow the visit down. You may want to ask the patient family to prioritize what their top 3 things they want to be addressed are. You might get surprised. Honestly, 2/3 of the time, visual hallucinations are not that bothersome to my patients. It's the runny nose, it's the constipation, it's something else, right? So trying to address those individually is important. And just notifying them that this is going to be a process, right? There's a lot of medications that can help with certain symptoms, but they're also very sensitive medications. So we want to do as much as we can, limiting variables that we're changing. And then just highlighting that it's a stepwise process, but it can definitely be worth it because we can make a difference in a lot of these day-to-day symptoms. Last slide here, this is just highlighting, we have this study that's going to be going on in Lewy body dementia. So you do have to have dementia for this study. So it is specifically more dementia with Lewy bodies. This is going to be an oral medication that modifies synaptic biology, and it's currently being studied in Alzheimer's disease, but this is going to be the first study in Lewy body disease. And these are kind of the things that it involves. We're going to be starting enrolling. I think we're on track for next month. So we'll be one of the first sites around America that's enrolling for this. So it's pretty exciting. This is our first Lewy body study. So if you've got patients that have dementia with Lewy bodies, please send them to our research team. I have to highlight that. There's no reason we have to see them in clinic if they've got a diagnosis, right? That should go straight to our research team to help get them enrolled. So I'm going to go ahead and I'll leave this slide up for a second, and then